Hello, everyone. Thank you for joining today's webinar, The Path to Effective Provider Data Management. My name is Charlene Serrano with LexisNexis as today's moderator, and on behalf of LexisNexis, I welcome you to today's program. Before we launch into the main presentation, I would like to mention a few housekeeping items. First, today's event will be about an hour long. You can expect to receive an email from LexisNexis within 48 hours with a link to the webinar recording and a copy of the presentation slides. At the bottom of your screen are multiple application widgets you can use. All the widgets are resizable and movable, so feel free to move them around to get the most out of your desktop space. You can expand your slide area or maximize it to full screen by clicking on the arrows in the top right corner. This is an interactive event. Feel free to submit questions to our speakers through the Q&A widget on your screen. We will use the last 5 to 10 minutes of the webinar to answer questions. Additional materials are available in the Resource Center. We encourage you to download any resources or links that you may find useful. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause issues. Webinars are bandwidth intensive, so closing any unnecessary browser tabs will help conserve your bandwidth. Some networks cause slides to advance more slowly than others, so logging off your VPN is recommended. If your slides are behind, pushing F5 on your keyboard will refresh the page. You can find additional answers to some common technical issues located in the Help widget at the bottom of your screen or the Troubleshooting Guide in the Resource Center. An on-demand version of the webcast will be available and sent to your inbox approximately 24 hours after the live event. Now I would like to introduce today's key speakers. First, we have Jeff Rifkin. Jeff Rifkin is the Research Director of Payer IT Strategies for IDC Health Insights, responsible for research coverage on ACA/HIX healthcare reform, payer business and technology priorities, constituent and consumer engagement strategies, technology and business implications for accountable care, risk, quality-based payment, and incentive programs, among other trends and technologies important to the payer community. And our final speaker is Dara Price-Olson. Dara Price-Olson is a Senior Director of Market Planning, responsible for the Provider Data Intelligence Suite at LexisNexis, which includes all provider information-related products and services offered by LexisNexis. The products of Verify HCP, Provider Master File, Provider Data Enhancement, Provider Data Validation, Provider Integrity Scan, and Verify RX are used by payers, plans, pharmacies, PBMs, and health systems to validate and maintain correct, current, and comprehensive provider information. And with that, I'll pass the presentation to Jeff.
Good afternoon. As Charlene said, I am the Payer Research Director for IDC Health Insights. My name is Jeff Rifkin, and I'd be glad to discuss provider data quality, their symptoms, their causes, and their remedies. Our topics today are going to involve the integrated provider data management situation and the convergence of accuracy of directories and adequacy of networks. We're going to talk about the gaps in the status quo, and we're going to talk about defining a path forward to achieve the enterprise provider data management that we all desire. First of all, let me introduce IDC. IDC is a service organization that provides market research and analysis, and we have over 1,100 analysts all over the world, and they pay me to discuss and research the payer strategies and the technologies that go with it. We have analysts in over 110 countries, and we have most of the quant about what software is bought and paid for across the world. But today's topic is about provider data management. And to start about provider data management, let's talk about briefly the drivers that we see at IDC as we publish all year and we write about the number of things in the payer area. And we're going to start with the drivers of the health industry. Now these three things, there were a number of them, but three of them jump out as indicators for this topic today. The first driver of the health industry is the race to innovate. It's not necessarily your size or your market share, but the fact that the speed that you have as a payer to change, deliver, and operate separates thrivers and survivors. There are thrivers and survivors in the payer world. I've written a number of reports recently about survival in the payer world, the relevance of payers in the health chain. These are not dramatic terms. These are realities. And the speed to change and the ability to move nimbly is a tremendous driver in the health ecosystem. And we'll see that later as we talk about the provider situation. The second driver in the health industry is the ability to sense, compute, and act on data, turning that data into value. Sensing data, either sensing it meaning predicting it, or sensing it in the case of like remote monitoring, the ability to compute data, the ability to take that data and turn that into information that is actionable, whether it be health outcomes or legitimate payments or legitimate risk assessments or other legitimate statistics to make the business run. That is a driver for the health industry. And again, separating the thrivers from the survivors, the ability to sense data, compute on it, and act on it. And the third has been talked about forever for the last 3 or 4 years. Ever since insurance companies have decided that it's not enough to collect premiums and dispute claims, they've decided that insurance industries have been interested in and been influenced by rising consumer expectations. Consumers expect convenience, customization and personalization, and control of their world. Similar to as the explosion of retail and other customer experiences are used to, it's not good enough for a customer to just be talked to quickly at open enrollment or whenever there is a bill to be done. Customers expect more, and we're going to see how that drives the provider data management philosophies that are necessary to compete in today's world. These drivers and other drivers are in our predictions report, and you can log on to www.idc.com and see these predictions, of which we refer to throughout the report. So now that's top down, from a driver's perspective, let's talk about why quality of data of providers matters to payers. It isn't necessarily intuitive to see how consumers are affected or consumers are bothered, but we're going to talk about how this back office function, provider data quality, matters significantly to the payer experience for members. The first thing is that it impacts members' access to care. The lack of quality data impacts the ability for a member to actually get care adequately. And the second is that it puts members at risk for out-of-network fees, which is absolutely unacceptable to anyone who's gone through this process. There's really a number of things around these two topics. The first one is how a provider's data quality matters in impacting a member's access to care. The first is fairly obvious. If a directory isn't accurate, the location, the specialty, in or out of network, this information is fundamental. A person's in a moment of stress. They need help. They need care. They look in their directory. They do the search, or they have an electronic directory, or even they even have a paper directory. And they understand that they want office hours. They want the right specialty. They want to make sure they're in network. And what's happening is these locations have to be precise. They cannot just say it's a particular building, or it has to be an office. It has to be Monday, Wednesday, and Friday for a particular doctor. It has to be correct. And if it's not, the network is perceived as inadequate by members, and we'll talk about that in a few minutes. So these locations, specialties, and network definitions have to be precise. Another interesting thing that's happening is the specialties that people are asking for are much more specific than they used to be. It used to be good enough to be a general practitioner and have a couple of specialties, this, that, and the other. Now you're seeing art-inspired autism therapists. You're seeing adolescent psychologists. You're seeing a variety of different detailed differentiators amongst specialties. So these specialties that people are looking for are much more specific, not just to raising consumerism, but as we learn more about the science around certain medicines, that specific specialties are precise, and it is important to get the right person for the right care at the right time. Members are also looking for a situation where they can actually communicate with their provider. And languages in this country are becoming more diverse, not just the languages that the practitioner speaks, but the fact that there's translation services available. in the office, not just once in a while, but all the time or whenever they are available, that has to be listed in the directories. So not only languages, but the language translation, both oral and written communications, very important to ensure members have access to care. The fourth area around why members' access to care is influenced by provider data quality is the fact that what's a provider is expanding. It used to be fairly straightforward. MDs and nurse practitioners. Now we're seeing therapists of all kinds. We're seeing spas. We're seeing grocery stores. We're seeing a number of flexible dietitians. We're seeing a number of packaged community services. Almost anything that can provide service to you can affect your health. And we're seeing that those services are at times being bundled into procedures. So the core information about what's a provider is not as simple as it used to be. It is expanding. And so the information around those providers, the quality of that information has to be significantly enhanced to ensure that we have a comprehensive package of information for members to get their access to care. And the last piece of the puzzle for accessing care is the explosion of telehealth. Over 90% of the payers in this country support telehealth at some level. And it used to be that telehealth was an adjunct network or was ignored totally. Now telehealth has arrived. People expect the ability to, on certain specializations, notably dermatology and mental health, the ability to use the telehealth network to achieve some of their objectives for health. Again, access to care. This information about the telehealth network has a variety of hands that go into the pie to figure out what time people are available, what the technology people use, and the sophistication of the networks that are necessary to execute telehealth. All of these things impact members' access to care. As we said, there were two things around how provider data quality matters to payer. The second was with putting the member at risk for their out-of-network fee. Anybody that's gone through that process where they walked into a situation where they thought they were covered by a network and covered by their copay and resulted in a bill of out-of-network, that surprise is not pleasant. It doesn't help that recently, over the last couple of years, there's been significant provider consolidation. A lot of onesie-twosie organizations, provider organizations, have been bought up by other organizations, other health systems. The organizations have been hard to follow and have moved over time. This can change within a month-to-month basis or a week-to-week basis. So the idea of a particular set of providers that used to have a set of rules and used to have a set of plans and used to have a set of insurance companies it worked with, used to have a set of office hours and so on, can change dramatically when an organization goes under another health system. So that's a confusing situation for members. The other thing is that providers and payers are consolidating. Over 50% of the health plans in this country are provider-owned now. And that, again, who do I listen to? Who is responsible for the directory? Is it my health plan? Is it my provider? Who owns who, when, and how, and why? Very confusing to the average person who's just trying to get through life and find a provider in an accurate way. And the last thing is the hospital privileging situation, which has been confusing forever. I mean, you hear the stories, horror stories about people go into surgery, they come out, and 95% of their entire procedure, the surgeon and the entire nursing staff, the building, the facilities, the drugs, everything was covered, but the anesthesiologist wasn't in network. And here comes the bill. And that's just, it's unfair, it's confusing, and it gets a lot of press. So again, what doctor has what privileges at what hospital, again, changes over time as their contracts are negotiated. Very confusing, and all of these things put members at risk for their out-of-network fees. Now we've talked about the themes we write about and the drivers for the health industry around what we drive about, and we've talked about why this all matters to the average member. So let's get down into it a little bit and talk about the symptoms of the provider's data quality issues. The first symptom is, as we've been talking about, an inaccurate directory. The second one is an inadequate network, and we'll talk about the difference between inaccurate and adequate. The third is that there's state and federal regulatory pressure that is coming and has come over the last 3 or 4 years as consumer groups have basically been very unsatisfied and very loud about how this information has affected their access to care. And lastly, we'll talk about inside an organization, inside out, how the back office has spent a significant amount of labor around this situation called provider data quality. The first thing is, and there's been some press on this, but what we found is that the biggest driver and the biggest, most visible thing around provider data quality is the ability for a directory just to be flat out inaccurate. We're finding that, for example, when one of the CMS audits was just executed, found that groups are listing all their providers at all their locations. You wouldn't think that would be difficult, and they do it because they don't want a claim to be rejected, so they just list everybody at all locations. Well, that's great if you're trying to process a claim, but it does not help a member if the indication was that Dr. Jones is in this particular address and this particular address and this particular address. It's just inaccurate. CMS's audits have found that over 50% of the providers surveyed have at least one deficiency. That means when you do a search, half the time the information you get is wrong. Whether that's individual location data, which has been found to be 39% bad, the phone number, just the phone number, the accurate is bad 13% of the time, and whether someone's accepting new patients or not is bad 5% of the time. This is how bad things are. And it gets a lot of press. Now, that's pretty obvious and pretty evident, but let's go underneath a little bit and talk about inadequate networks. An inadequate network is perceived to be, is in the eyes of the beholder. State legislators and consumer organizations have been fighting for years to talk about what inadequate means. And what it really basically means is a diverse, broad network is desired. Now, what does diverse and what does broad mean becomes a function of the eyes of the beholder. Some states are more aggressive than others. Some states are more willing to have fines than others. But basically, it's a legislative process to ensure that the insurance plan that files with the state says that we have an adequate network, whatever that means for that particular jurisdiction. It used to be that adequacy was defined as time and distance. Do I have so many doctors in so many zip codes? And so on. It's not just defined that way anymore. Information like, is it close to transportation? Does it have the language that's necessary to speak? All of these things are now being introduced into adequacy. So it's very difficult for an organization who's trying to meet the bogey of what a legislature defines as adequate. It's a moving target. It's not just time and distance anymore. Add to this that payers got a situation where there's a shortage of providers now. The nurse practitioners are taking on more and more roles in the medical chain, and organizations are trying to figure out how we're going to have an adequate network in this situation where there's a shortage of providers. At the same time, payers are trying to implement narrow networks, which are trying to help cost and improve quality by creatively using network design to both help members and reduce costs. Lastly, we've got the National Association of Insurance Commissioners and, of course, ACA had a significant amount of requirements about what adequacy means. So the combination of federal and state situations and the overall ecosystem of health makes network adequacy a very interesting situation that is now being perceived by brokers, payers, and employers as a differentiator. For example, in California, State Bill 137 is a great example. In their goal to drive accuracy, they've defined a very prescriptive process. They dictate how often a payer has to reach out to a provider and how they should do it, and how inaccuracy should be resolved, and how often to update your directories. They even dictate that if a response isn't received, that the listing must be removed from the directory. So aggressive states like California even put into legislation the procedures that are necessary to ensure that we have what's perceived as an adequate network. The payers are responding. Payers are trying to figure out ways to make this happen, make the states happy, and make the members happy. A third area around The symptomology of data quality is, again, we talked briefly about this, but the mandatory compliance that's happening, the mandated, legislated, state-based compliance, where frequent outreach, you must talk to the payer within this amount of time. You have to have these fields in your directory. You have to have this network adequacy. You have to be able to ensure that people perceive your network as adequate. And if legislators don't perceive your network as adequate, then when insurance plans go to the state and ask for a creative network design with a narrow network, and they're being perceived as maybe cherry picking, that's not good for the plan. So again, there's a whole reputation of a big bad insurance company with the state legislature, which all comes to head with network adequacy. Now, at a global level also, the horror stories of network adequacy and directory accuracy are great fodder for the single payer advocates who have this ammunition if the payers don't address the situation. Again, this isn't going to drive you to single payer, but it sure doesn't help the press. And lastly, the situation with, obviously, we talked about California bills. There's also been class action lawsuits in California, and a number of fines have been implemented by CMS and at the state for organizations who have perceived and proven that, at least in court, that these organizations were not in good faith trying to serve their members adequately with network adequacy and directory accuracy. And the last situation is sort of an inside-out thing for payers. There's a significant amount of work that goes into keeping this stuff up. The frequency of data is changing. 30% of the provider data changes every year. The degradation seems to be about 2% a month. It's very unpredictable. There's not necessarily an accountable party. You've got contracts with antiquated systems that a lot of them have to be wet signs. There's a lot of paper flying around, manila folders, file cabinets. It's a very interesting perspective. And when you start talking about the back office and the amount of weight that the manual processes that data quality provides. Provider data also used to be only in the claim system. You used to need just enough provider data to get the claim through. Well, that's changed dramatically. Now provider data is its own ecosystem. It sits in onboarding a provider, credentialing the provider, contracting with the provider, maintaining the directory of the provider, appeals, grievances, all over the organization. Provider data is necessary, and it better be right. There's lots of sources and methods to gather this data. And the bottom line is, if you get nothing out of my talk today, just think about for every correction, every match, every investigation, every compliance report, there's a set of people, processes, software, and methods. A lot of work, a lot of people, and it's very expensive. Now, with that as a baseline, we have this situation where payers are trying to move into bundles. And they're looming out there. And when you have a bundled situation, as we talked about briefly a minute ago, you have brand new provider affiliations. So, the knee replacement we all hear about that has, the surgeon and the anesthesiologist and their operating room and the facility and the bed and the drugs and the PT and the MRI all come into a bundle. Well, all of these providers now have to be associated. They have to be affiliated so you can contract out the bundle. And again, you have to have a core set of base data that's accurate so you can put these pieces together to build the bundle. Either organization or financially, you're going to have a different kind of affiliation than you did before with the value-based. Add to that all the care coordination agreements, the formal PCMH panels, the referral networks, the contracting bodies, the shared risk pools. All of this has to be put together, and the only way you can do that is your base data is accurate. So that pretty talks about the symptoms of quality. Let's go to a polling question.
So we want to take a minute here and hear from our audience. This is interactive. So those of you that are listening in, this is a live polling question. We want to know from you, which challenges cause you the most pain or difficulty? Is it the regulatory and legislative pressures related to inaccurate directories? Is it the regulatory and legislative pressures related to inadequate networks? Or is it the labor-intensive internal operations? So we want to give you about 30 seconds there to give us your feedback. What are the biggest challenges for you? Which of these causes you the most pain or the most difficulty? And your answers should be populating shortly. Just want to give everyone a few seconds there to go ahead and let us know which challenges cause you the most pain or difficulty. All right, so let's take a look. Wow. Across the board, highest in labor-intensive internal operations. 82%. Is that what we expected, Jeff?
There is a lot of work going into them, and I guess some of those people are on the phone. The back office effort around this process, especially in the flexible nature of the new contracting arrangements and the risk-based pools, is definitely painful. This has not surprised me, but perhaps it's also the lens of the people who are here. If you were to be talking to a bunch of government relations people, you might get a different kind of set of answers. But obviously, the back office is yelling real loud that this is a problem. Not surprising at all. So let's move on briefly and talk about the causes of why we're paying attention to this stuff. We started top down and we talked about symptomology. Now let's talk about why now. Why is it important now? And the first one is obvious, I hope. It's the age of consumerism for payers. It's not good enough to just be there for open enrollment and to be complained about when things don't work out. You have to be the member's partner in care, and we'll talk about that. The other causes also, as we list here, network strategies, the changing contracting landscape, and the fact that providers are calling their outreach excessive, and we'll talk about that in a minute. But the first one's fairly easy. Again, it's not good enough to just collect premiums and dispute claims or argue about appeals. If payers are going to maintain their relevance and not be disintermediated by employers or concierge services or direct pay, the payer has decided that the payer is your partner in care as a member. That's the new mantra. Look at all the commercials, look at all the marketing advertising, look at what's happening, and payers want to be your partner to help you maintain and manage the health ecosystems at your time of crisis. That is the new mantra, and people are expecting legitimate service. Maybe it was the exchanges a few years ago, and maybe it was ACA, and maybe it was the fact that people that could go onto these websites and find insurance in a little more straightforward manner highlighted the fact that the search capabilities for a provider were providing such lousy results. I'm not sure what it was, but I think it's a confluence of efforts that have come together where consumers are much more interested and much more aware of the fact that their provider directories are not accurate and sometimes their networks are not adequate. So payers have decided that higher levels of service, getting providers to collaborate, and getting member satisfaction scores way up are real important to them. And I think all payers that I work with, which is a number of the 500 health plans around the country, we're finding that the member satisfaction is in the top 5, or at least the top, maybe even the top 3 of things that people are working on and throwing money at a significant level. To the point where a differentiation of brand is occurring with directory accuracy. If someone's got a bad directory, it absolutely makes a difference when people are choosing their health plan. The statistics are, for the people who are using the exchanges, for example, that over 50% of the people who sign up for insurance using the exchanges switch the next year. They're not happy with the service, or they're not happy with the price, or maybe they get more informed of what they really got. But the bottom line is, if you have a bad experience trying to find a provider with your directory, that sure as hell puts you off. So you've got a situation where organizations are really working toward loyalty, and these people who know that they can switch, and they're doing so. So consumerism is a big cause of the recent attention. The second cause is, again, narrow networks. Payers are working them, trying to define cost and quality and ensure that the people are served while the network is optimized. Adequacy, we talked about briefly. Adequacy is not just time and distance. It's whatever the legislature defines. And sometimes it's a rabbit's hard to catch. And behind that, the states are implementing fines. So as a network manager, it's very difficult to try to figure out exactly what you're shooting for, but these strategies are causing organizations to pay attention to data quality in the provider area. The third area is, again, we talk about value-based. Network and contracting, everything is changing. It was fairly simple, straightforward with a fee-for-service and a PPO and HMO contract. Now you've got creative, competitive, provider payer contracts, and it's necessary to have a legitimate set of provider data so you can come to the table with your providers and have a legitimate set of negotiation tactics and a legitimate set of provider data to work from. You've got to have the flexibility to establish these sets of provider affiliations, or you're going to be left behind. You will not be a thriver. You will just be a survivor, if that. And we talk again about networks are being analyzed, networks are being narrowed, networks are being analyzed and sometimes being fined, both at CMS level and at the state level. And the last thing is a sort of a subtle thing, but it's important. But the provider back office is pretty tired of talking to the 6 insurance companies it deals with on a regular basis 3 times a month to confirm and recognize what their information is. So they're calling it out excessive. They're contacted by phone, by portal, they get alerts, they get emails. They're tired. And on the payer side, the accountable and knowledgeable parties aren't necessarily on the phone when you call them. So I talked to one payer that said, I don't talk to the first person who answers the phone. I make sure I get the office manager or something like that. On the other hand, providers don't want to remove that provider-specific location information because they don't want claims denied. So sometimes it won't necessarily be accurate, but they want a broader definition so they get their claims through. So sometimes they're working at cross purposes. It's a very interesting situation when an organization is working across purposes and you're trying to get valid information. And I think we're up for we're back over to Dara, and we're going to talk about the next polling question, I think.
Great. Thank you so much, Jeff, and thank you again for joining us today. I really appreciate it. I like how your background really puts things into context. You talked a lot about how the market needs have been evolving and expanding, and we're going to talk now about how the current approaches and tools, so to speak, need to evolve as well to meet those needs. But before we do, we're going to do just a quick poll to talk a little bit about one of the common approaches we see happening in the market, which has to do with provider outreach. Charlene, if you want to take us through that.
Absolutely. So again, we want to hear from you, our listeners out there. We want to know, are you finding outreach and provider response to be an effective way to drive provider data quality? Please rate this on a scale of 1 to 10, with 1 being not at all effective and 10 being extremely effective. So again, we want to hear from you, our live audience, and know, are you finding outreach and provider response to be an effective way to drive provider data quality? If you can rate that from 1 through 10, 1 would mean it's not at all effective, and 10 being extremely effective. So we'll give our audience a few seconds to go ahead and participate here so we can see what the majority has to say. Okay, it looks like our answers are pretty varied. It's pretty high around a number 8, 5, 3, so it's pretty mixed. Was that what you expected?
Yeah, that's pretty interesting. If we were to take an average, I'm guessing that it would come out at about the 6, and I'm not surprised. I think that makes a lot of sense. We ourselves are seeing that it's effective when you couple it with other activities as well versus depend on it solely. Okay. So, let's see here. Okay. So let's move on, though, to talk a little bit about the three big gaps or issues that we see with approaches overall, and to a certain extent, outreach is boiled into some of these activities as well. So the first one here has to do with ownership and governance, and the second is the tangled web of redundant information exchanges, and then lastly is data is maintained in silos with pretty minimal automation from what we've seen. So first is the issue about ownership and governance when it comes to provider data and provider data quality. So at the heart of the issue is that accountability falls to the payer. And these are for reasons that Jeff already talked about kind of extensively, so I'm not going to go into it. But the payers themselves, or the health plans, are extremely dependent on getting much of the information about the provider from the provider organization themselves. And you really do need to have their cooperation in order to get it. And I'm not saying that providers are uncooperative or they don't care about keeping payers up to date with their information. They really do care. But from the conversations that we've had with different practice groups, I know they work really hard to keep them informed, but that sometimes that knowledge is spread between different parties. So we see that practice administration knows a lot of the location details, and the enrollment and credentialing folks own their other pieces of the picture. So to pull it all together and make sure that you have high quality of the whole profile, essentially, of that provider can be really difficult. And that isn't even including when you have the situation where the credentialing or enrollment functions are delegated. Then that gets even more complicated. So to pull together all that needed information can be super complicated, because who do you go to? What one person do you go to that knows all the answers or can supply that information? The next point is the topic of how there's a redundant information exchange. Sometimes I've heard Jeff talk about this being a tsunami of information, and that's a pretty apt description. What you have going on here is you have providers and groups that are sending or sharing their information for each payer plan that they work with. And then to flip it around, the payers and plans are also reaching out to confirm information in order to meet regulatory requirements. So you have information going in both directions. And not only that, you have it happening through multiple methods. You see emails, you see calls, you see rosters, you see portals. I've even heard of an exchange of PDFs, which obviously that can be super difficult to manage, very difficult to automate. And I know that a lot of times the details of the exchange can be different for almost every point-to-point interaction. I was talking with a practice administrator not that long ago, and they were describing how they have literally a library of SOPs that they have to follow whenever they have a provider information change. And they have a different procedure that they have to follow for every health plan they work with. And believe it or not, this diagram is actually a bit of an oversimplification. What it isn't showing is when delegated organizations or credentialing organizations come into play, and then it's also not showing the multiple departments or systems within a payer. When you kind of expand to look at that full data flow end to end, you can see how complicated all of this can get. So let's just say you do succeed in getting the needed information from the provider group to the health plan. Then the next point you have here is that once the information is received within a health plan, there's often, at least from what I've seen, there are multiple places where that maintenance occurs. So this is kind of the ecosystem that Jeff was talking about, where provider information is used throughout a payer's organization, and the different operations have different dependencies on different information. So the best example is how tax ID doesn't show up on a directory at all, but it's absolutely critical to claims processing. And while phone number really doesn't matter much at all to claims processing, it's absolutely critical to directories. Now, when it comes to practice address information, it becomes even more interesting, and Jeff talked about this a little bit as well. I mean, for claims, you really need to have any practice location where a provider could legitimately provide service so that a claim won't be denied or kicked out for manual adjudication. Usually, a system needs to have all those locations loaded in order to meet their prompt pay rules or ensure payment integrity. So for claims, the more service locations you have in your data sets, the better. But for directories, you really should be listing only the practice locations where a provider regularly sees patients, and not every location where they could provide occasional coverage. So for directories, when it comes to service locations, the fewer the better. But then, if you have too few, you run into network adequacy challenges. So it's really, really a difficult balance. These competing priorities have payers trying to strike that balance, and in many cases, we've seen it's resulted in almost departmental management of information, where each silo is responsible for maintaining the provider information needed to meet those priorities. I've actually seen some of the SOPs that payers have to follow to make the changes on their end, and it can be super complicated with interrelated steps and some of them being manual. So let's just do a quick poll on this one. Charlene, if you want to walk us through this.
Sure. Once again, this is interactive. We want to know from your perspective, what issues present significant barriers to provider data management? So we have a few options here. You can select between ownership and governance, or a tangled web of redundant information exchanges. And the last option is data maintained in silos with minimal automation. So again, we want to hear from our audience and know what your perspective is as to what issues present significant barriers to provider data management. And for this one, you can select all those that apply, so you don't have to select just one option. So that can be either ownership and governance, or a tangled web of redundant information exchanges, or data maintained in silos with minimal automation. So we'll give you just a moment there to go ahead and select all that apply, and we can see what our poll results are. Okay. About 50-50 looking at a tangled web of redundant information exchanges and data maintained in silos with minimal automation. Interesting.
That is super interesting. I'm not surprised to hear that, although I do think it's interesting that fewer people are seeing that ownership and governance being an issue. But let's go ahead and kind of move on to look at where we stand then, where this actually, the net result is. So basically, here's the net result. There's a heavy health plan investment, which seems to only be getting heavier. There is a heavy provider burden, which is only getting heavier. And meanwhile, there's very little evidence that directories have improved, at least according to CMS's Medicare Advantage directory review results, which all in all, it means that patients and members still aren't quite getting the service levels that they need. So we're going to talk now about the path forward. So we just talked about the payer-provider data ecosystem. We're going to zoom out a little to look at the bigger picture. So beyond payers, there are other stakeholders as well. I mean, obviously the consumer is a stakeholder. We talked about that already. But beyond that, you have other healthcare industry stakeholders as well. You have providers themselves. You have pharmacies and PBMs. You have life sciences organizations. And, of course, you have the payers and health plans. And each one of these organizations has their own similar ecosystem of operations that use and maintain information about providers. And because they all depend on it for their operations, they all actually hold critical information and insights about those providers as well. Their activity, their whereabouts, their contact information, their claims, and all of that. Every single one of these stakeholders knows some critical information about the providers. But everybody has data though, and what we're really talking about is trying to get to quality data. So each of these stakeholders have a need for high quality information, as we talked about. And just quickly to talk about what we mean when we refer to quality, we're talking about accuracy, which is timely, reflecting real life, and authoritative. I think timely is pretty obvious, but when it comes to authoritative, we should just go into that a little bit. I mean, obviously, when it comes to phone number, there really isn't a better authority than the provider organizations themselves. But you can't just take their word for it when they say that they're licensed. So license information has its own authority, which has to come from or be confirmed by the state licensing board. That's what we mean by authoritative. Consistency means that you should be getting the same answer system-wide. And here I put the system in quotes because things like whether or not a provider is accepting a plan or participating in a plan, you better be getting the same answer from the provider group as you are from the payer. Otherwise, you're going to end up with a disconnect when your claim gets processed. Next is completeness, the depth and breadth. Just very briefly, when we talk about depth, we mean like all provider types, and we mean all valid answers for that piece of information. So address is a perfect one. Lots and lots of valid addresses for a provider, maybe for different uses, but there are lots of valid answers for that particular data attribute. And then the next is breadth, and Jeff talked about that, about the growing need for the breadth of information. You're seeing a lot more interest in things like languages spoken and accessibility options and those types of things, a greater demand for those things. And then there's relevance, which means appropriate for the purpose. And I always like to pick on address. Address is another one, right? An address might be fine for billing purposes, or address might be fine for claims purposes, but it might not be fine for scheduling an appointment, that type of thing. And the final point here in the middle is talking about sustainability, because achieving and maintaining a high level of quality ongoing and is extremely labor intensive. There really needs to be a sustainable model to keep up with that rate of change. We talked about what the needs are and who the stakeholders are. We talked about the need for quality and sustainability. So really, how do you get there? Okay, so this is a really fun picture. After 15 years probably of working with provider information with the different healthcare verticals that we support and use it, we've come to look at it in this way. We call it the Provider Data Exchange Hub or the Provider Data Oracle. And we've really come to view this across the 4 major industry consumers of provider information, which are shown here in the fingerprint icons. We've already talked about who those guys are. But as we talked about, because their operations depend on provider information, they also have intrinsic knowledge about the provider activity, and I love to pick on this one. If you look at pharmacies, for example, pharmacies are filling prescriptions, which requires the prescriber to be licensed and have a valid DEA and to not have any sanctions, right? Those key credentials of about 80% of the scripts filled in the U.S. are confirmed at the time the prescription is filled against the primary source information that we have on those prescribers. And if the prescription is pended because the license is showing as expired or because the service address is unfamiliar to us, it kicks out to a remediation process for immediate review. Now, Jeff talked about that moment of stress. And there's a moment of stress when you're receiving care, but there's also a moment of stress when you're trying to fill a prescription. When your child needs their ADHD medication for the new term that's starting on Monday and you're there on a Sunday night, you need that prescription to be filled right away. And that, as you can imagine, is really driving and requiring a very high level of quality. Then if you take it a little bit further, beyond the primary source information, you have this practice location specifics. So for that, we're using rosters and a provider portal along with payer contributory data from the plans and supporting it with supplemental outreach. Now today, we're using most of the contributory data to drive and prioritize outreach, but we see it coupling with our claims and our artificial intelligence or our analytics activities to drive more and more insight over time. And we're going to talk more about how we're using AI and machine learning today coming up a little bit, so I'll leave that point for another slide. But lastly on here, there's real-time or near real-time, blast that animation. Here we go, let me get it. So there's the real-time or the near real-time push and monitoring of changes and pushing those changes to the people who really need it. So if you bring it all together, this whole hub kind of notion provides a balance. So it reduces the dependency on any one method and allows the data from the different evidence that's out there to vet and challenge and allow you to identify where the anomalies are. So like as an example of that, what I'm talking about is, we might be showing them, they might be shown on a directory listing, right? But really, are you really providing service there when you're not submitting claims from there or not submitting claims from that group? Are you really providing services if you've stopped writing prescriptions? Are you really performing services there when your license has gone inactive? All of those things can be really good at kind of challenging and making sure that the information that's flowing out there is backed by actual facts, right? So when you look at things this way, you can see that there's a lot of potential. And we keep asking ourselves, how do we take this to the next generation? How do we bring healthcare and make it smarter than it's ever been, right? If scripts can be confirmed against key credentials and sanction information real time, why can't medical claims, right? Why is re-credentialing only performed once every 3 years when really it can be done every single day, at least for the key attributes? Beyond insight from remediation, couldn't new artificial intelligence be developed on top of the prescriptive activity? And can't outreach for directory verification be done only upon exception when other information indicates there's a change in practice patterns? Really, all these things are possible, and they're just a small stretch from where we already are now. So what does that mean? What does this model mean from a practical perspective? So just to kind of, in the interest of time, we're going to hustle on here. It means that you can have an opportunity to detangle that web, remove the redundancy, supply information through the hub once and have it distributed to the necessary parties. The next is, to be an oracle, you have to be more than a messenger. You have to add that wisdom and intelligence And this is where the AI and machine learning comes in, is you use irrefutable facts and activity to really provide that oversight. I'm going to just show you a really quick visual of this because this can be really difficult for people to visualize. This is a real group. This is real analysis that we have done on this particular group. This is a group in the Southwest region with 52 providers and 41 service locations. Everywhere in this square box, you can see there's an intersection of a provider with their location. They're listed 2,052 times within the directory. You overlay that with the information that we have and the claims activity that there is, along with other information about those practitioners. And you can see that two of the providers don't work for the group anymore. And of this entire picture, only the green boxes indicate valid directory locations. But the yellow ones are also appropriate for claims. We've found this to be extremely helpful insight to get to the bottom of what's right and what's wrong and what's relevant for what purpose. And we've seen it to be actually more reliable than provider response in some regards. The last point here we talked about was how the hub facilitates near real-time sharing of information. As I was showing in the hub diagram, up-to-date information can then either be pushed through deltas or alerts or pulled via APIs to make that sure the changes get from the people who know from the people who need to know. So this can then support more industry interoperability. And once that information is available to payers in a timely and standardized way, then really any system with API capability can tap into it. So on the subject of tapping into the hub, I'm just going to talk about how this model works. I mean, while there's always more and advancements made all the time, and some of those ideas are still conceptual, the meat of what we were talking about of this hub, the core of it already exists and is available. So the ways to tap into it is you can tap into it through a subscription service where you define your selections and get the profile of information sent back to you on a regular basis up to daily, and then also can be sent with just the changes only. You can do essentially a comparison and cleansing process where you can send the information and get back where the issues are, where the gaps are filled, which also has an option for just changes or deltas pushed ongoing. And then lastly, there's the notion of real-time access through a web interface or APIs to facilitate that decisioning right within your workflow. So just to wrap things up here, Jeff started this out with talking about why provider information matters and highlighted the issues with it today. Then we talked about what's not working with the current approaches. And then we ended up with describing that hub model that enables high quality information in more of a sustainable way, not only for payers and providers, but for the other industry stakeholders as well. So we left just a very couple minutes available for questions. Why don't we see if we have any we want to take here?
Sure, and at this time, as we receive any questions from our audience, just a reminder, if you have a question, you can submit it using the Q&A feature. I do see a question here. Dara, you may want to take this one. How is the Provider Data Exchange Hub any different from the blockchain initiatives that have been going on for provider data?
Oh, wow, that's a really good question. Because there has been a lot of blockchain activity. You know, the way at least we've been looking at it is, I mean, blockchain, it's a technology really. It's a very powerful technology, but what we've seen so far is that they've mostly been based on the payer participants. and relying heavily on where there's overlap between the payers' information that they have about providers. You know, I know we've done some analysis on this ourselves, and where the provider information isn't backed up by other data sources, we found it takes roughly 4 to 5 payers needing to have the same information before you can get results that you can actually trust. And you know, we really do think that almost any of the blockchains would benefit from some level or some type of Oracle services.
Thank you, Dara. And for the sake of time, we want to thank you all for joining us. This does conclude today's presentation. Thank you for your time, and please watch for our follow-up communication. We look forward to having you join us again.